The next speaker is Dr. Venkatesh.
Good afternoon, everyone. Ultrasound, as you know, has become a very important clinical tool in the assessment of critically ill patients. And it certainly goes a long way in the assessment of the critically ill obstetric patient as well. Over the years, there has been a lot of refinement with the basic technology of ultrasound. Although the same kind of technology has been refined, today we have portable machines that you can take to the bedside and make repeated assessments using a variety of probes depending on the clinical situation. And it is particularly important, I feel, in the obstetric patient to be able to tell what is causing dyspnea, which is a very prominent syndrome, very prominent symptom in many critically ill patients. And if you look at the lung, you will have the answer to most of these situations. And to look at the lung, you use a probe similar to that you see on the screen now. It is a microconvex probe shaped like a finger, which enables positioning between intercostal spaces, and you get an excellent view of the lung if you use a probe like this. You can use other probes as well, but this probe, which is similar to a transvaginal probe that you use, is found to be extremely useful in our experience as well as with the experience of other people as well in looking at the lung. Now, what do you look at in a dyspneic patient, and how do you image the lung? This is my own lung, just to demonstrate to you what it looks like. I'm holding the probe with the probe marker pointing to my head, and the probe is placed just below the clavicle. Starting from the top, that's actually the skin, superficial tissue, muscle, and finally, that's my pleura. The first indication of any kind of movement is the pleura. I'm sure you can see a white line that moves from side to side. That indicates the pleura. This is a normal pleural movement that you see. And below the pleura, you have the lung, which is nothing very distinct in my lung. Hopefully, I am pretty much normal, so you won't see anything there. Now, that's again my lung, but look at this particular lung. It is very easy to tell that something seriously wrong here. You can see the pleural line there, that's normal. You can see the pleural line here as well, moving from side to side. However, if you look at the pleura closely, you can see several radiating band-like lines which arise from the pleura, moves with the pleura, side to side, and reaches the bottom of the screen. Now, what does that indicate? This indicates interstitial lung fluid. If you see this in your patient, there is only one reason why it happens to be there. That's because there is interstitial and intraalveolar fluid in your patient. If you see it bilaterally, extensively, it indicates pulmonary edema. The pulmonary edema may be of cardiac origin, or it may be of non-cardiac, as in acute respiratory distress syndrome. So if you see this, it means there is fluid. And it is a very strong suggestion that your patient may not take any more fluid. In fact, your patient, she may need to be diuresed to get rid of this problem if it is indeed cardiogenic pulmonary edema. So it is, as I mentioned, fairly simple to distinguish. These are called B lines, or comet tail artifacts arising from the pleural line. This is an extreme patient who has severe pulmonary edema. You can see the lung is almost like completely whitened out by these thick B lines. It represents a complete whiteout on the X-ray as well. Talking about X-rays, if you need to evaluate a patient with X-rays, obviously you need to call the radiographer, needs to shoot picture, you need to get the picture on the screen or a hard copy. All this is going to take time. But you have a machine by the side. You know the answer within a few minutes' time if you have basic skills. Now, is the lung in your patient getting inflated at all? That's another question that you need to answer. The lung may not get inflated because a tube that you pass to ventilate may have gone down to the right or left main bronchus, and the other lung may not be ventilated. So if you see a pleural slide here, it means that lung is getting ventilated. However, just watch here. You can see the pleural line. This is starting from the skin muscle pleural line. But can you see any pleural movement here? Absolutely none. It means that lung is not getting ventilated for some reason. And that reason could be because of pneumothorax, as you see here. In pneumothorax, you see the pleura slides halfway, but the other half doesn't slide. If you see something like this, absence of pleural slide, and this is called lung point. The pleura seems to slide partially. So if you see this, it means your patient has pneumothorax. So that's how you diagnose pneumothorax on ultrasound. In many of your patients, especially preeclampsia, they become fluid overloaded over time, especially at least among some clinicians, there is a tendency to fluid fill them a little bit indiscreetly, I might say, which results over time in fluid overload, which typically gives rise to those B lines that I showed before. And it can also give you this kind of picture, which is maybe some of you can guess. It is a massive pleural effusion that you see here. The lung is floating within the fluid like a jellyfish. It's called jellyfish sign. So pleural effusion is, again, very well recognized on ultrasound. You just need very minimal training. The second question that comes to mind in a critically ill obstetric patient is, my patient is hypotensive. What is wrong? Is my patient bleeding? Or is my patient, does she have peripartum cardiomyopathy? Or is my patient hypovolemic? How do you know? One, look at the heart. You need not be a cardiologist to do this. If you have an echocardiography probe, most machines do have it these days. And if you look at the heart, you will be able to tell if your patient is hemorrhaging or not by looking. I'm sorry, this video is not playing, but it just goes to show that if you see the cardiac chambers look very small, right ventricle and left ventricle, as you see here, if they look very small and if they collapse in systole, it indicates that your patient may be hemorrhaging and your patient is hypovolemic. So that is a good sign to suggest that your patient may be hypovolemic. The second method is to look at the IVC, which is the inferior vena cava. To view the inferior vena cava, you need to have a probe like this. It's a curvilinear probe. You place the probe in the epigastrium like this, and when you do that, you get a short axis view of the IVC, which is a cross-sectional view, as you see here. And then you turn the probe around to get a long axis view of the IVC, as you see here. Then once you get a long axis view, you can measure the IVC diameters on the M mode. You measure the widest diameter and the narrowest diameter, and there is a formula to look at the difference in diameters. And if you get more than 12% difference, it requires a little bit of experience, I must say. If you get a significant difference between the widest and the narrowest diameters, it means that your patient is hypovolemic, maybe due to hemorrhage, maybe due to other reasons. And anybody who has basic ultrasonological skills can place a probe in the pelvis or in the hypochondrium to look for free fluid. In many patients, there may be intraperitoneal bleed due to a scar rupture or due to a ruptured ectopic pregnancy, for instance. And it's a pretty simple thing to identify free fluid within the peritoneal cavity using a low-frequency probe. The other important question that you often ask in a pregnant woman who comes to you breathless, struggling to breathe is, does my patient have pulmonary embolism? Pulmonary embolism is many times more common in the pregnant population than in normal women. And this is because the Virchow triad, which classically leads to pulmonary embolism, is very prominent in pregnancy with hypercoagulability, endothelial damage, and stasis. And to look at, to diagnose pulmonary embolism in pregnancy is it's not so easy. Firstly, you cannot expose the mother to irradiation, preferably, unless if it's a life-threatening situation. Secondly, D-dimer, which you very often go by to rule out pulmonary embolism, can be highly non-specific, and also it may be elevated in pregnancy, in normal pregnancy as well. And in that situation, and of course, you should also consider the fact that treatment of the patient based on doubt in pregnancy with anticoagulant medication, which may be acceptable in a non-pregnant situation, might lead to a catastrophe in the pregnant woman. So not only do you need to diagnose precisely, but you need to balance the benefit of treatment versus the harm that you might cause from it. And that's where bedside ultrasound, of course, it is not the be-all and end-all of the diagnosis of DVT and pulmonary embolism, but if you see something by the bedside, it certainly will give you a very important clue. And to look at the veins of your lower extremity by compression ultrasonography, you use a high-frequency probe like this. I will just take a couple of more minutes. What you need to do is you need to place the probe in the inguinal region and apply pressure. When you apply pressure, you will see, in this case, that's the vein and that's the artery. You can look very closely. You will find that I'm actually compressing the artery by my pressure, but the vein is not compressing at all. My pressure is so much, it is higher than the systolic arterial pressure, and it compresses the femoral artery, but the vein is not compressed. Why? Because there is a clot in the vein. If you see this, you don't need to go any further. It is DVT. There is no doubt about this. It can be nothing else. Of course, you might argue that it may be an inguinal lymph node, which you might mistake. But that degree of expertise, of course, you should have. And then if you see this, it means that it is DVT. And the treatment of DVT is the same as for pulmonary embolism. You need not investigate any further unless it is strongly indicated. And this is the same patient on the short axis view again. You can see a clot within the femoral vein. That is a femoral artery. And of course, bedside echocardiography in acute massive pulmonary embolism has very typical features. Of course, you should be warned about the fact that in milder pulmonary embolism, there may not be any echocardiographic signs at all. But if in your patient who is severely breathless, that is a normal heart, which is a normal apical fourth chamber view, as we call it. That is the left atrium, that's the left ventricle, right atrium and the right ventricle. And that is the normal size of the chambers as you see on the screen. But if you see here, if you see should come. Just a moment. Sorry about that. It should play. Okay, so that's a normal sized chambers. If you see here, it is not at all normal. Perhaps you can guess. You can see that the right atrium and the right ventricle are bigger than the left atrium and the left ventricle. Normally, the RA-RV is not more than half the size of the LA and LV. But in this case, you can see it is bigger. So that is indirect indication that in your patient, in a given situation of acute breathlessness in a pregnant woman, if you see right-sided dilatation, it's a very strong suggestion that your patient may have acute pulmonary embolism. So this is very briefly how you would assess your critically ill obstetric patient with a little bit of guidance to begin with. And if you keep on doing it time after time after time, like with anything else in life, you will become an expert over time. Thank you. Thank you so much.